Maddie, the one and only Maddie is going to discuss with me. Thank you, Maddie.
Hey everyone, I'm so excited to co-discuss with Sharmin. It's always so much fun and it's really nice to see so many of you guys here. And I'm excited for Yaz, I believe, to be presenting a case.
Woohoo!
Yeah, that's right. I can give you the chief complaint, a little bit of HPI, because I know that this is technically a 30-minute VMR, but yeah, like, what do you think?
You're the boss. Yeah, is what I
Okay.
feel much. We'll just follow your lead. A shout out to Haria and Ulpreet for doing teaching points and scribing today. All right, if you can get the board up, we can get started.
Of course. So, we have a 31-year-old male presenting with bilateral upper extremity swelling and pain. Would you like me to give you a little bit more information, or do you want to discuss this chief complaint?
Maybe a little bit more.
Okay, for the HPI, this patient presented after having 3 days of bilateral upper extremity swelling and pain in his bilateral forearms, wrists, lateral and medial epicondyles, shoulders, and ankles. The pain was not relieved with over-the-counter analgesics. He took acetaminophen. The swelling had become progressive and included a dull throbbing pain and tingling in the bilateral upper extremities. Uh, he mentioned that these same symptoms happened a year prior with a self-resolution. Would you like some review systems, or would you like to start there?
Yeah, I guess we can start here. Maddie, what do you think?
Yeah, this is such an interesting start to the case. So just to summarize what I heard to make sure we're solving the right problem. So I heard that this is a 31-year-old gentleman who's presenting with bilateral upper extremity swelling and pain with also associated with some tingling. I didn't quite catch the time course, so I'm sorry if I missed that, but that will be a key detail here.
Yeah, he mentioned that this bilateral swelling started 3 days ago.
3 days ago.
And then exactly as again with exactly the same with pain, bilateral tingling and pain, upper extremity swelling.
Yeah, okay. Well, yeah, thank you for such an interesting chief concern. When I heard just bilateral swelling, often I just start to assume this is in the lower extremities because that's what is more common, at least from my experience. But I think what's interesting about the bilateral upper extremity, what's different about approaching that type of edema versus lower extremity is that it's not gravity dependent. So oftentimes when we think of bilateral lower extremity edema, we're thinking of, volume overload from, we often think of the different organ systems, the heart, the liver, and the kidney, if it's in a gravity dependent. But I think that that is actually not the way I would approach this one because it's the bilateral upper extremity. And so it's not gravity dependent. So I think my mind is going to two places. My mind is, number one, thinking, is this a type of presentation of anasarca, where perhaps all four extremities are somewhat involved, and maybe the patient is noticing the bilateral upper extremities more than the others? In that case, we would, want to be solving the problem of anasarca. Or if it's truly just the bilateral upper extremities, the first one of the things that my mind went to is there a problem with venous drainage, basically? Is there something like, SBC syndrome, for example, where there's compression of the venous drainage that's causing fluid to build up just in the upper extremities? So I think what's really interesting about this chief concern is that the way we approach the swelling, and which I'm translating to edema, is really influenced by the location here, by the fact that it's if by the fact that it's just the upper extremity. So I think I'm most concerned of a venous drainage issue that could lead to swelling in both of those extremities. It would be unlikely, I think, for it to be just a local problem, like a cellulitis in one arm, because I wouldn't expect that to happen bilaterally. So I am thinking of something that's um, obstructing the venous drainage from the upper extremities, whether that's a mass or something else. I haven't yet tied in the tingling yet. I think I've just noticed that my mind first went to the edema. We'll see if maybe on exam if there is some neuropathy there, and in which case we'll have to incorporate that. But yeah, I think I would want to understand a little bit more of the associated symptoms, the fact that this happened 3 days ago, what occurred 3 days, if there was exposures, if he was doing something different than usual with his arms. And you could also do certain exam maneuvers to test the hypothesis of the venous drainage, like is it worse if he raises his arms above his head, for example. Sharmin, what are your thoughts?
That was so awesome, Maddie. I can just listen to you discuss cases forever. That was brilliant. I completely agree with you. I think it's notable that it's like acute in onset, and I agree that thinking about venous drainage and thinking about like is there any obstruction at any level that has led to bilateral upper extremity. The other thing that I would just add is like inflammation, as you mentioned, less likely to have like bilateral hand cellulitis, but any systemic inflammatory conditions. And since it involves the wrist and the shoulders, I think I would like think about joints as well, whether that joints are actually involved as well. Is it just inflammation of the joints that he's perceiving as like sorry, I can't talk. Inflammation of the joint that is then he is perceiving as like inflammation of his upper extremity. So I feel like exam would be quite helpful to help us distinguish that. And the other feature of this case that is fascinating to me that this has happened to him before and it's self-resolved. So what to do that with information? I don't know. Is it the same thing? I have no idea. However, I think it does bring up the notion that what if this is a more episodic a syndrome that we're dealing with, or it's true and unrelated. I think we just need a bit more information to get to the bottom of it. I really like you were thinking about exposures. So yeah, I think the question that I'm looking for going forward is there any clues that lead us more to the inflammatory pathway, or are we dealing with like edema in the bilateral upper extremity? And edema has to start somewhere. I love that you were thinking about anasarca as well. So I'm really curious to for Yas to tell us more.
Of course. So a little bit more information. The patient mentioned that he started experiencing generalized malaise and fatigue that seemed to correlate when he was experiencing these increased joint pains, since it's not the first time that he experienced them. He denied weight loss, subjective or objective fevers. He denied any aphthous ulcers, facial swelling, sun sensitivity, rashes, hair loss. And he also mentioned that he noted chest pain, left-sided chest pain, and mentioned getting this intermittently. Denied shortness of breath and coughing. And for the abdominal, he mentioned that he had no abdominal pain, no vomiting, no change in urinary symptoms. When asked a little bit more about his any other symptoms, he actually admitted that he had intermittent finger pain in cold weather with skin color changes, but that he never paid a lot of attention to them. Do you want more medical history?
Yeah, that would be great.
Okay. So for the past medical history, he mentioned that there was a possible history of Raynaud in his mother, but that she never got a symptomatology, a diagnosis. Also mentioned that he had chronic recurrent polyarticular arthritis, but didn't see a PCP for this. Medications, none. His mother again had a history of systemic lupus erythematosus and rheumatoid arthritis. For social history, there is no tobacco use, no alcohol use, but had chart history of previous admissions for heavy intoxication. He denied drug use. For allergies, He mentioned ibuprofen allergy. If Amal, I can help you with the scribe. Would you like more information on physical exam?
And I think this is good. I'm sorry, Yas, my internet got cut out and I missed the review of systems. So he had a bit of chest pain. Is that right?
Yes, he mentioned that he had intermittent chest pain,
Mhm.
left-sided, but with no shortness of breath and no dyspnea.
And then he just had the finger, like kind of right notes.
Yes, that's something that when asked, that he never really paid attention, but he noticed this discoloration in his fingertips on cold weather.
All right.
Mhm.
Um, Okay, wow, fascinating. So, the more Yas is revealing, the more I'm getting more worried about like kind of autoimmune inflammatory syndromes, uh, given the kind of like multiple system involvement, right? We have like, as he has like some joint issues, he has perhaps, this inflammation of the soft tissue or skin that we still need to better examine with physical exam, and this possible of like Raynaud's syndrome, and also with family history of underlying family history of autoimmune disease as well. So, in terms of like a Raynaud's syndrome, it can run with many different autoimmune diseases. So, vasculitides, uh, it's one that comes to mind as well. The one thing that, just kind of taking a step back with someone, he's like 31 years old, with like intermittent chest pain, it does makes me worry about kind of like the vasculature a little bit. So thinking about, what the upper extremity, like blood goes everywhere. So are we dealing with any underlying autoimmune disease that has a vascular features that affects that is something that comes to mind. I think Yaz mentioned that he doesn't have any like oral ulcers or stuff like that, which is like helpful to make like kind of Bishop syndromes and a little less likely. So I think exam kind of figuring out what joints are involved, getting your baseline labs would be really helpful. And again, like, I wonder, Maddie, what do you think of his like age and like autoimmune disease? Like anything that is like jumping out to you?
Yeah, I'm 100% with you. I think a summary of like what I took away from this aliquot is that this is there seems to be systemic involvement here and concern for an autoimmune process given both his past medical history and the family past medical history. And I'm right there with you that it's, this is a young gentleman, 31-year-old male. Um, and then it's like what really stood out to me is that Yaz said he has a past medical history of chronic recurrent polyarticular arthritis. Like that seems so unusual for a 30-year-old male to have chronic polyarticular arthritis. So I was very struck by that, and I'm curious if this is an autoimmune process, if this is a flare of that, kind of be curious to see what workup the patient had for chronic current polyarticular arthritis in the past. But I'm right there with you that I'm concerned for an autoimmune etiology of this. And I think I'm also very curious for the exam to see to what extent the joints are involved. I really loved your pickup on that in the very first aliquot where I was kind of focusing more on the swelling, but you recognize that he's also reporting, pain in these joints. So is the main problem really an arthritis associated with swelling rather than swelling being the dominant issue? So I'd be very curious to see if there's swelling, redness, if there's like limited range of motion. Um, the things you don't want to miss is there a septic arthritis picture on top of this, even though it would be relatively unusual to my understanding for that to be polyarticular. But those are kind of the thoughts that stood out to me.
Beautiful thoughts, friend. All right, yes, we're at the edge of our seats.
Yeah, amazing. I really like the way that you're tackling this case. Now, for his Vital signs, his blood pressure was 129/87. His respiratory rate was 16. His temperature was 36.5 Celsius, like normal. And heart rate was 108. His saturation is 97% on room air. In general, the patient appeared in discomfort, but not in acute distress. He had moist mucous membranes, no oral lesions, no erythema appreciated. On his cardiac examination, there was tachycardia noted with regular rhythm, normal S1 and S2 sounds, no rubs, murmurs, or gallops. The chest wall pain is reproducible to palpation. The patient was asked to breathe in, breathe out, and it didn't really reproduce the pain until palpation, just to make sure that I'm explaining the physical examination correctly. In pulmonary, he had normal respiratory efforts, clear breath sounds bilaterally, no crackle, no whistles. And for the abdomen, there was no tenderness to palpation, irregular bowel sounds. For the musculoskeletal exam, we have bilateral forearm muscular tenderness to palpation. There was also tenderness to palpation on wrists, epicondyles, in the cleniohumeral joints, and we also found medial and lateral malleolar ankle joint tenderness. Although when examining the patient, only the wrist joints had effusions or edema. There was also cervical C-spine tenderness from C3 to C6. In his skin, we saw multiple calloused and ulcerated appearing lesions on several fingertips of both hands. Neurological exam was no focal neurologic deficits, cranial nerves grossly intact. I'm looking at Maria. I hope I am explaining correctly the neuro exam. There were normal reflexes, some hyperalgesia in bilateral forearms, but no decreased sensation. There was decreased grip strength related to the pain in both hands, but otherwise no motor deficits were noticed. Oops. That's all the exam.
Oh my gosh, yes. This is such an interesting case and such a rich aliquot of information. So, just to summarize some of the things I'm seeing, so just starting off from the top, the vitals, what stood out to me was tachycardia here. The rest of the vitals seemed stable to me. And then really getting into the physical exam. So to summarize what I'm hearing, it seems that, of course, we'll get to the joint exam, but prior to that, it's most notable for chest wall pain on the left that's reproducible to palpation, but we're not seeing from the history shortness of breath, and we're not seeing any hypoxemia associated with that. And then from the extremity exams, what I'm hearing is that there are multiple joints involved, including bilateral wrists, bilateral elbows as well, and then bilateral ankles, with only the wrists having effusions. And then we're also seeing the notable skin exam of the ulcerated lesions on the fingertips. So I think the key details, in the last aliquot, we were concerned about a potential autoimmune etiology, and I think that is reinforcing that. I think what I'm really focusing on here is the polyarticular involvement. That's what I'm choosing to focus on most. And whenever you have, polyarticular involvement, there are many buckets I think of. So even though I'm focusing on autoimmune, there are still other etiologies to consider here. So one bucket is infectious etiologies. So you can have, rheumatic fever, post-group A strep, that's kind of has a migratory arthritis. We're not seeing that here, but that's like one etiology in the infectious bucket. You can even have kind of Lyme disease, causing polyarticular involvement. You can have viral etiologies like HIV or parvo causing polyarticular involvement. Then we get to even crystalline diseases here. So you can think of gout that can affect multiple joints. The autoimmune category here. So the ones that come to mind for me are lupus that can involve multiple joints, RA, Still's disease. And then in addition to those, you can have the spondyloarthritides, that those are the ones that are, ankylosing spondylitis, reactive arthritis, psoriatic arthritis, IBD associated arthritis. And so those are the types of buckets I think of with this polyarticular involvement. I think, going back to the autoimmune category, trying to incorporate the skin findings, systemic sclerosis is something that came to mind when I saw the ulcerated lesions on the fingertips. I would have to review the illness script for that. I'm not sure if does that commonly present as polyarticular involvement. I'm just not sure. So I would in real time probably be looking that up. But that is a consideration for me. But I think in terms of what I would do next, I would actually go back to the chest wall. That's just one thing that I feel like I haven't been tied that in together. And I would really want to take a look at the skin in that area. I think the fact that it's reproducible to palpation, but we're not getting any indication of like a deeper issue, no cardiovascular compromise in terms of the vitals. I'm more concerned of like a superficial process on that. So I would want to see if is there a rash in that area, for example? Is it kind of a muscle issue? So I would want to do a thorough skin exam of the chest wall, especially where the area of pain is, even like zoster, that can cause that like localized pain. And then I would send off a lot of basic labs, things like an ANA as well, because we're concerned for an autoimmune process. And then if a joint can be tapped, I think that would be helpful. I think Yaz said that now I'm forgetting if you said the ankles or the wrists had effusions. The wrists. That could also be helpful too, to kind of get synovial fluid so that we can analyze it. Charmin, how are you incorporating all of this, and where is the differential in your mind?
Honestly, no better than you. That was fantastic, Maria. I think what I really, really love that you did is like, again, try to summarize the physical exam and then say like, okay, what is the problem I'm trying to solve? And I love that you based your schema on the polyarthritis because that's something we know that he has like multiple joint involvements. And like I loved your ways of thinking about rheumatoid arthritis, like lupus, not forgetting about the infectious etiologies because we are like so down the autoimmune path. I really, really love that. And then slowly layering on other findings. That was like absolutely, absolutely brilliant. And to answer your question about systemic sclerosis, yeah, in terms of like I might be wrong, so please somebody in the chat with more knowledge can correct me. But I know sometimes like they have like hand arthritis or DIP joint involvement, but the diffuse joint involvement is not something that I generally associate with systemic sclerosis. But please, somebody definitely correct me if I'm wrong. You know, if he wasn't 31, I would say like this is kind of has a little bit of RA flavor to me, right? Like it has the shoulder, the wrist involvement, like RA sometimes have like cervical axial involvement as well, but again, axial is a little less common than like peripheral joints. But like Raynaud is not something that I generally associated with that or ulceration. So I wonder about like an overlap syndrome. I mean, going back to thinking about like, could I mix connective tissue, active synthetase, and, like especially with the calluses in the hand, like if that is like more like kind of like the mechanics hands, that is like associated with it is like another one that comes to mind. That all being said, just also not forgetting that like it sounds like, the chest is a chest wall tenderness, but again, in someone who is coming in inflamed, I just want to make sure, get your ECG, get your troponin just to make sure. Again, 31 is quite young, but not to forget that. And so yeah, I think like getting our basic labs and then serological workup, I think tapping a joint is a great idea as well. So I'm right there with you. I don't really have much to add. That was fantastic, Maddie. I'm so impressed.
Yeah, just picking up what I love how you went through that, Sharmin. I think anti-synthetase syndrome, I have not seen that. I've just heard it in VMRs, but that stood out to me as some way, there could be multiple processes happening, but if we're trying to tie it in, I believe that you can have like kind of the calluses on the hands, the polyarthritis, polyarthralgia or arthritis, and the Raynaud's. I think that was a really great idea of a way to tie it all together. Yaz, what happened next? We're so
Okay,
curious.
so I have labs, the basic labs and imaging, which I can give you both aliquots. So just for the sake of time, for the CBC, we have a white blood cell count of 8.9, hemoglobin of 11.7. His MCV was 77.5. Platelets were 207. For his BNP, sodium was 138. Potassium 3.6, bicarbonate was 24, chloride 106, BUN 7, creatinine 0.7, his glucose was 84. For liver tests, his AST was 572, his ALT 160, ALP 215, his total bilirubin was 2. Direct bilirubin 0.8. His UA had 3 plus protein, 3 plus blood. His urine protein was 282. His urine creatinine was 263. His UPCR ratio was 1.07. His urine drug screen was negative. We also had a TSH of 2.95, which is normal, an ESR of 3, and CRP was 4. And I can show you a chest x-ray that the patient had. I'm having some, there it is. Let me know if you can see it. So on this chest x-ray, we saw an enlarged cardiac silhouette concerning for cardiomegaly versus pericardial effusion. And the bedside ultrasound revealed a large pericardial effusion. Let me know whenever I can stop sharing my screen. Those would be like the basic labs and imaging. The next aliquot would have the additional labs and a second part that may reveal diagnosis.
All right. Just for the sake of time, I might just like go through this a little faster. So if you can go back to the board, that would be great. All right. So just like looking through the labs, we're so at this point, what we are looking for, right? We are looking for any other organ involvement that could help us figure out what type of autoimmune disease that we're thinking of or dealing with, right? So, the AST ALT being elevated, the question for me is that a liver thing or is that a muscle thing? A lot of the diseases that we are wondering about have myositis as part of their presentations. So again, just for the sake of time and being concise, you want to make sure if the liver is like truly involved or not. So sending GGT, getting your imaging, And then also giving a thought if, some of the ASC and everything is like coming from muscles involved. Uh, Again, like the proteinuria, definitely qualifying that. I didn't catch the creatinine, but it sounds like a creatinine is normal. So if I like take a step back and see what organs are affected, right? So we have like skin manifestation, potentially lung manifestation, potentially cardiac manifestation, potentially like this joint RA like manifestation. It doesn't fit perfectly, but the more I hear, the more I worry about um, kind of the anti-synthetase syndrome, some of these overlap syndromes that we've been talking about. So I think and that can also have like a cardiomyopathy associated with it as well. So that is what I'm most worried about at this point. Maddie, what jumps out to you?
Yeah, I am right there with you that it's clear that many organ systems are involved. I think from this aliquot, we really got a flavor. You're right, the creatinine is not elevated, but the UA is abnormal with both protein and blood. And we had talked about lupus as a potential that this could be potentially compatible with the skin involvement, the serosal surfaces involved, the joints, and also the UA that you can have lupus nephritis. So I would want to kind of explore the glomerulonephritis more with getting complement levels, even sending ANCA serologies, because as you said, a vasculitis can involve multiple organs because the vessels go everywhere. So I would be sending complement levels, ANCA serologies, ANA, anti-double-stranded DNA to like evaluate the lupus. And then for the anti-synthetase syndrome, I don't know if you send is it an antibody you send? I'm not sure. I would have to look that up. But exactly there with you, with many organs involved, concern for an autoimmune process, and maybe lupus as a way that could tie this together.
I love that you brought lupus. I don't know if Robbie is here or not, but one of my thing is that I always miss lupus. It's just like my thing. When I have to think about lupus, I know. When I don't think about lupus, so it's kind of like my pulmonary embolism. The thing is like whenever you think it's pulmonary embolism, it's not. Whenever you don't think it is, it's like that's lupus in my world. That is always. That's a fantastic thought. And yeah, I 100% agree with you. I think anti-synthesis is like it's anti-Joe. I think it's ANA and anti-Joe, I believe. But somebody please correct me if I'm wrong. So yeah, but I think like beauty of that, Maddie, is you can always look it up. And you know, I'm not I'm not very good with these antibodies as well. So I just have a list of them in my notes that I can like
Yeah.
reference and look up, and I don't remember all of them. So
I think that's the way to do it. Why would you remember all of them? You should have a list.
I can't remember them all. So using our external brain.
Yes.
But I love your thought of like working the glomerulonephritis up a little bit more. And we'll see what that shows. Yes.
Okay. And I'm like impressed. I really love listening to you guys discussing. And the chat is on fire. And a shout out to Anmol because this is quite a lot, like a lot of information. And brace yourself, everything you have asked for, you shall receive. I have the additional labs. Just before I continue, would you like to have all of them because they will reveal the diagnosis? Is it okay?
Yeah, just given the time, yeah,
Okay,
that
perfect.
would be awesome. I think we can like pontificate about this case for a long time.
Okay, so for additional labs, he had an hepatitis panel HIV test negative. His CK was 7,587 units per liter. Aldolase was 40.4. Ferritin was 1,292. His SSA and SSB antibodies were 2 and 8, respectively. Rheumatoid factor was negative. His anti-RNP antibody was 135 units, which is high. Anti-Joe was 7. SRP was negative. C3 was 8. C4 is less than 1, which both are normal. ANAs were positive, with speckled titer was higher than 1 to 2,560. His double-stranded DNA antibody was 388, which was super high. Anti-Smith antibody was 290. CH50 was 12.5. And those are all the labs.
All right.
Take it away, Maddie, because you crushed it.
Well, I think I would want to clarify a little bit because, of course, there's a few things that stood out to me. Of course, positive ANA, then positive anti-double-stranded DNA, the anti-double-stranded one being more specific for lupus. So I believe we can make a diagnosis of lupus with this case. I know some of the other antibodies. Yes, if I heard you correctly, did they return positive? I'm just trying to.
Yes.
Is there lupus plus something else, or is this just lupus?
For RMP antibody was 135, I think. There it is, anti-RMP. We also had a CK of 7,587, which is super high. And yeah, like those are basically the most interesting labs I have for you.
So interesting. Yes, I would have to, I don't know off the top of my head what anti-RNP, what syndrome that corresponds with. Do you know, Sharmin?
Anti-RMP, is that
For mixed connective tissue disease.
connective tissue? Thank you.
Yeah.
Thank you. Yeah. Yeah. I agree with you. Again, lupus. Oh, I should rewatch episodes of Friends. No, House. Sorry, House, where all of this is lupus. So for it to say, yeah, I think like lupus. The question is like, is it just lupus alone, or are we dealing with an overlap syndrome? Just given the joint involvement and everything else, I worry that the patient has like an overlap syndrome of some sort as well. But again, lupus can do all of these, and I think kind of looking back. Just doing a little bit of a cognitive autopsy on myself. I think I jumped into anti-synthetase a little too fast. I don't believe it has as much renal involvement. So I think like Maddie, you picking up on the glomerulonephritis, I think was like such a key point. So thank you for that.
Oh, this was so much fun to discuss, Sharmin, and yes, what an interesting case. Yes, I'm curious how you're like if you took care of this patient, what it was like, and how you were how did you put this together? Were you saying this was lupus, or was there an overlap syndrome as well?
I didn't see this patient personally, but I did get all that information as well as the case resolution and the diagnosis and a cognitive autopsy actually. This patient was, for rheumatology was consulted, and based on serologies and complement levels, he was diagnosed with systemic lupus erythematosus with lupus nephritis and myositis. Cardiology was consulted for possible drainage for his pericardial effusion. However, given his overall stable vital signs, they elected not to perform a pericardiocentesis or a pericardial window. He was initiated on 60 milligrams of prednisone daily and hydroxychloroquine 200 milligrams daily. He also received a renal biopsy afterwards during admission that showed lupus nephritis on a stage 3. He got his pericardial effusion got worse. So later in his hospital course, he received a pericardial window and was ultimately discharged on a prednisone taper, hydroxychloroquine, and mycophenolate. And of course, kept on follow-up with cardiology, rheumatology, and nephrology. The thing with this patient is that for the cognitive autopsy, during the workup, the team did a query SLA plus myositis overlap versus mixed kinetic tissue. But because he did have an MRI finding afterwards consistent with myositis of the bilateral forearms, which made them think about this possible systemic lupus erythematosus and myositis overlap. They also questioned this possibility of the scleroderma in the mix as well, but they felt it, and they felt unlikely this being rheumatoid arthritis given the lack of joint effusions. And also they even investigated the possibility of steels, but they discarded it due to the lack of eosinophilic myositis. So that's basically what they were thinking. And myositis, they thought about myositis because the AST is usually elevated to a greater degree than ALT, because AST is mainly on muscle cells. That's why they added myositis into the mix.
Wow. Yes, my mind is blown and feels like it went on like a marathon run. That was fantastic. Again, lupus, 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 lupus. It's my takeaway. But yeah, it's the challenging presentation of it. And just the ulcers in the hand, they just thought that was from rhinos.
Yeah, they actually, that's why they started like investigating this was scleroderma. But again, the antibodies were negative. Honestly, I really didn't consult what happened after in follow-up because he kept being followed by rheumatology. But that's basically it, like an overlap of systemic lupus erythematosus, lupus nephritis stage 3, and myositis.
Yeah, beautiful. Yeah, I know this was such a fantastic, and I feel like with the autoimmune diseases, you're like uh doing like a 2000-piece like jigsaw puzzle that you have to like see how they put together, what's causing what. But sometimes like rhino phenomena, if they have like for a really long time, it can cause ulcerations in the head. So I wonder that if it's all lupus, then maybe perhaps that was a rhino phenomena that led to it as well. So many things to learn, so many things to reflect on after this case. Maddie, you did such a fantastic job discussing this case. I would have not made any progress without you. So kudos to you. Thank you so, so, so much. Yaz, what a brilliant case. Thank you so much to Anpreet and Harry. And Mike, to you, Harry.
Great case, everyone. Awesome discussion. Just a few teaching points. Upper extremity edema, as Maddie had said, is not gravity dependent. So if you're paired with upper and lower extremity edema, think of something systemic, which is something Maddie caught on to very early on for this patient. If it's isolated to the uppers, just consider something about impaired drainage, plumbing problem, really, versus joints, inflammation, or swelling that can be perceived as edema. For our differential diagnosis for polyarticular arthritis, there are many things, but think about infectious causes, some crystalloid disease, lupus, RA, Sjogren's, the spondyloarthropathies, vasculitis. Just something I add is that patients with autoimmune disease are increased risk for thrombotic events. So for suspecting autoimmune process, having MI and differential for this gentleman's chest pain, just to keep in the back of the mind. And then AST elevations can also be seen in myositis, not just purely liver manifestations. And then I threw in some test characteristics, not for memorization, but just understanding that some of these antibodies can be really helpful guiding our differential for these different autoimmune processes.
Harry, I think you're muted.
Oh, sorry. All I was saying is that these test characteristics can be really helpful in guiding our differential. For example, double-strand DNA is nearly 90% specific for lupus. Smith is actually almost 99% specific for lupus as well. And RNP is 100% sensitive for mixed connective tissue disease, but also can be seen in lupus, just like in this patient as well. And that's it.
Thank you so much, Harry. I love how clearly you kind of broke through the key teaching points. That was phenomenal. And Yaz, thank you so much for this case. It was so much fun to discuss. I'm gonna reflect a lot on it. And Yeah, those antibodies, they're so tricky because there can be so much overlap with them. But so much fun, Charmine. It was a blast to co-discuss.
Always so much fun. Thank you so much, everyone. Thanks for joining us. Hopefully, we'll see you tomorrow.
Bye.
Bye.